Psychiatry, Pathology, Childhood and Early Onset Disorders. All right, so first we're going to be discussing about ADHD, which is Attention Deficit Hyperactivity Disorder. And they named it relatively pretty well because, once again, these patients are going to be presenting with a deficit in their attention span, and they're going to be hyperactive in different situations. Now, the key things to kind of look out for is that you have inattention or hyperactivity that interferes with functioning in greater than or equal to 2 places. So if you see that this patient is presenting with problems of kind of maintaining attention or with problems with hyperactivity and at home or at school, like at home and at school, then they're talking about ADHD because it's greater than or equal to 2 separate places. If they're only having problems at school, then it's not ADHD. Okay? If they're only having problems at one location, it's not ADHD. Now, it doesn't have to be home and school. It could be like home and church. It could be at different locations, right? But it has to be at least 2 locations or greater. All right. And it presents with like hyperactivity, impulsivity, and inattention. All right. But that greater than 2 or equal to 2 is huge. Okay. That 2 setting is massive for ADHD diagnosis. And you're going to notice it when taking the exam. All right. Now, usually you're going to see it in males, and the onset is usually going to be before the age of 12. And what they want you to know is that when a patient has ADHD, it can present later on in adulthood with disorganization, and it causes social impairment. So if you see later on in adulthood a patient that's severely disorganized and they have social impairments, think about a misdiagnosis when they were younger of ADHD. Okay. Now, the way that you treat it is stimulants. Okay. So methylphenidate is one key one that they like to ask about. And then you can also use atomoxetine or alpha-2 agonists like clonidine. All right. But stimulants like methylphenidate is pretty much the number one first-line therapy. They can go for behavioral therapy too, but stimulants is methylphenidate or atomoxetine. All right. Next is autism spectrum disorder. So autism spectrum disorder overall is very, very high yield. You're going to see the onset in early childhood, and it's usually going to be a male, okay? Males are very key to this, okay? It's going to be 4 times more likely to be in a male than it is in a female. You're going to have no eye contact with the child. So that's like one of the first signs that they like to talk about is that they lack eye contact. They have social and communication deficits, and you will see repetitive behaviors. Okay, repetitive behavior. So they're going to be sitting in a corner repetitively, I don't know, like one example could be like repetitively rolling a truck back and forth, back and forth, back and forth, back and forth. Okay, if they keep on saying that they're interested in just like this repetitive behavior, then it could be due to autism spectrum disorder. It's accompanied most of the time by intellectual disability or above average abilities. Okay, so they can have a deficit in their learning, or they could be a savant in their learning, which is specific skills. So they could be a savant in like music. So if they are very, very good, or like savant in dates, they know certain dates on when things happen throughout history. And that's something that's very highly associated with autism spectrum disorder. And the last thing that you need to know is that it's associated with a large head size. So if you see an increase in circumference of the head, then you know that you could potentially be dealing with autism spectrum disorder. Okay, so keep that all in mind as you're dealing with ASD. I would say like kind of the key features here is males, early onset childhood. They have social and communication deficits. They have repetitive behaviors, and they could be accompanied by intellectual disability and or like savants in certain types of topics. Next will be conduct disorder. Conduct disorder is going to be repetitive, pervasive behavior that's violating social norms. Okay, so what does this specifically mean? This is someone that's going to be like very, very destructive of property and theft. So when we say violating like norms, social norms, they're going to be breaking the law. Okay, so like they could be like burning things. They could be torturing animals. They're going to be aggressive in nature. They're going to be destroying property. They're going to be stealing things. Okay, very, very key to understanding conduct disorder is kind of what types of things they do, right? So they like to violate norms. They like to violate the rights of others. They like theft, property destruction, and hurting animals. Okay, so those are 3 key things that they always bring up in question stems. Now, what you have to know is that conduct disorder is present before the age of 18. If you see the same symptoms in a patient after the age of 18, then it's going to be known as antisocial personality disorder. It's the same thing, but they just change it up for pediatric versus adult populations. If you're under the age of 18, it's conduct disorder. If you're older than the age of 18 with these same exact symptoms, it's the same exact disorder, it's known as antisocial personality disorder. They try to trip you up all the time on this, okay? Don't let them get you. After the age of 18, it's antisocial personality disorder. So antisocial is for adults, A and A. Conduct disorder is for children, C and C. Okay. Now, what they like to do is treatment for CBT. Okay. So cognitive behavioral therapy. If you're ever in a pickle, pick CBT first. I mean, unless you know the answer, obviously, for the treatments. But if you ever kind of confused for a psych question and they're looking for treatment and CBT is an option, you could just maybe guess CBT. That could be an educated guess. All right. Next is disruptive mood dysregulation disorder. This is like severe recurrent temper outbursts that's out of proportion to the situation. Okay, the child's gonna be constantly angry and irritable between outbursts, but they're not gonna be violating social norms. They're not gonna be destruction of property or stealing things from people or hurting animals. So that's the difference. It's lower yield. Another lower yield thing is going to be intellectual disability. Once again, it's just a global cognitive deficit that you're gonna see with intellectual disability. Next is intermittent explosive disorders, okay? What the key thing here is that the patient's going to be remorseful after, okay? After their explosive event, they feel bad about it, all right? And they're gonna be remorseful when they're adults, okay? The onset usually is after age of 6. And once again, the episodes are followed by remorse and they're out of proportion to provocation. So just like disruptive mood dysregulation, they're out of proportion to the situation, but to contrast them, intermittent explosive disorder is followed by a remorseful phase. They feel bad for yelling, okay? That's very key. Next is oppositional defiant disorder. This is one of the higher yield things like ADHD or conduct disorder. This is another high yield one. And what they want you to know is for ODD, it does not include stealing or like physical harm, okay? Or physical aggression. It's mainly just like aggression towards authority figures. So it has to be towards authority figures and lasting greater than 6 months. Okay. So you're going to think, oh, it could be conduct disorder, but conduct disorder is going to be more severe. Okay. Those conduct disorder patients are going to be like destroying property, stealing things, killing animals, hitting people. Oppositional defiant disorder, they're defiant against authoritarian figures. So that could be like specifically like teachers. All right. So keep in mind their defiance is towards authoritarian figures, not anyone else. So you wouldn't expect it anywhere else except for in situations where there's an authority figure. And it has to last greater than 6 months. Okay, so that's the differentiation between oppositional defiant disorder and conduct disorder, where conduct disorder is just pretty much, it doesn't matter if it's authoritarian or not. They're just going to be crazy. All right, and oppositional defiant does not include like the crazy stuff of like stealing and hurting animals. Next is going to be specific learning disorder. So specific learning disorder, if you see a patient that's like performing relatively well, but then they also are performing below expected in other topics. So they're performing well in some topics in school, but they're below expected in like either math or reading or like writing. Okay, so if they're like below expected in one of those specialties or one of those classes, but the other classes they're doing fine in, that's specific learning disorder. Okay, so like if you're good at like reading and writing, but then they say like they're like struggling a lot in math for quite a while, despite like a bunch of interventions and tutoring and stuff like that, then it's a specific learning disorder. Okay. All right. Next is Tourette syndrome. Tourette syndrome, they love to just talk about motor and vocal tics. So you're going to see like grunting and clearing throat. Okay. So they love to present it in question stems like the patient was grunting or he was clearing his throat a lot during the time that the physician was in the room. They're not giving you specifically like Tourette syndrome, right? What we would expect that we see on social media and things like that. They're just trying to hide it. They're masking it with like motor and vocal tics, like grunting or throat clearing, okay? That's like another thing. Or like grimacing is another thing, smiling or shrugging their shoulders. Those are another motor symptoms that you'll see or motor tics that you'll see, all right? Now, what they want you to know is that it waxes and wanes, okay? So it's not continuous, right? And then it also is associated with OCD and ADHD. That's pretty much Tourette's syndrome overall. Next and lastly is Rett syndrome. Rett syndrome is essentially, the way that I think about it, autism spectrum disorder, but for females. Okay, so if you see a female with similar autism spectrum disorder symptoms, it's probably most likely going to be Rett syndrome. But I'm going to give you the the 4 most important things that are associated with Rett, and you should get it every single time. Rett syndrome, 1, highly associated with girls and females. Okay. Number 2, you'll see a decrease in head growth, decrease in head circumference. Compared to autism spectrum disorder, you'll have an increase in head circumference, and it's going to be in males, right? Number 3 for Rett syndrome is that you'll have abnormal repetitive hand movements. All right, and lastly, you're going to see a progression in cognitive and motor skills, but then it will randomly stop and it will regress. So it will be you'll see a loss of speech and motor skills, or cognitive and motor skills. So they call it a regression of cognitive and motor skills. So if you see a normal female infant as she's growing, but then randomly she starts to regress in her motor skills and her cognitive function, she starts to have abnormal hand movements and her head circumference starts to decrease, then you know that it's going to be Rett syndrome. So remember 4 things: higher in females, decreased head growth, you'll see repetitive hand movements, and loss of speech and motor function. All right. So overall, that's all you need to know about the childhood and early onset disorders. It's relatively straightforward. That's why psych is one of majority of people's favorite topics, because it is so easy to kind of pick out what they're asking in each question stem.